Today we'll talk about some thing that we see fairly frequently in the proctology clinic and often get consulted even in the emergency room to manage, and that is perirectal abscess. Now, perirectal abscess is significantly different than a perianal abscess, and it's usually very easy to tell the difference by physical examination alone, particularly when performed by someone who's treated these different maladies. Now, as far as perianal abscesses, those are treated by lancing and usually resolve. And perirectal abscesses, on the other hand, in the acute phase are also treated very similarly. Now, the way this presents is individual may initially think they have a hemorrhoid, it just doesn't get better, it gets worse, and then all of a sudden there's significant swelling, they may get fevers with it, and on examination you have a painful red tender mass, which may be fluctuant. Now, we can usually numb this up fairly well as far as numbing the skin over it, but numbing the skin over it doesn't actually get rid of the pain, because the pain is from all the pressure that's built up within the abscess cavity. So once the skin is numb, then we can remove the skin overlying the abscess, and sharply removing the skin allows the pressure to subside, and individuals feel significantly better almost immediately. As far as antibiotic usage, in immunocompromised individuals, we recommend antibiotic uses, as well as in individuals who may have other signs of potential sepsis, as in tachycardia, high fevers as well. However, we don't routinely administer or prescribe antibiotics for individuals who have simple perirectal abscesses that are drained. As opposed to an anal abscess or a perianal abscess, perirectal abscesses do require a follow-up, and usually we would have the individual follow up in the office if they have recurrent symptoms, or to follow up within 1 to 2 weeks, regardless of whether or not they have recurrent symptoms. This is basically because 1 out of 4 times these abscesses actually have an underlying anal fistula, and if that is not caught early and treated, then you can have recurrent perirectal abscesses, which can make the disease more difficult to treat, as well as cause significantly more pain and suffering for the individual with the disease process. As far as what to look out for during follow-up, you would expect that within a week to 2 weeks, the symptoms should completely resolve, and they should no longer have any drainage or discharge from the area. However, if the symptoms recur, or they have persistent drainage of either pus or dirty appearing liquid, and sometimes even gas from the area, then that is concerning and needs to be further managed.